Welcome to today's in-service. Somewhere on your next shift, a patient is going to look at you and say, "No thanks, I'm not going." How you handle that moment is one of the highest liability, highest stakes interactions in EMS. Today, we're going to break down why patients refuse care, how to talk them through it the right way, and how to document it so that you and your patient are protected.
By the end of this session, you should be able to do 4 things. Recognize why a patient in front of you is saying no. Walk them through risks, benefits, and alternatives in a way that actually lands. Confirm they understand what they're deciding with a teach back, and know exactly what to do when the refusal is high risk, including when the patient in front of you is a minor and there's no parent on scene.
Refusals, sometimes called AMA, against medical advice, happen in roughly 5 to 10% of EMS encounters, and in some systems more than that. That means it's not a rare event, it's a daily reality. Every patient has the right to make their own decisions about their body. Our job isn't to override that, it's to make absolutely sure they understand what they're choosing before they choose it. And here's the uncomfortable statistic. Providers get sued over refusals more often than over the calls where they actually transported someone. That's why we're spending a full in-service on this.
Here's a detail that matters more than most providers realize. Who brought up refusal first? If the patient says, "I don't want to go," before you said a word, that's a very different conversation and a very different documentation trail than if you're the one who first mentioned it as an option. Suggesting refusal yourself is a slippery slope with liability. And be honest with yourself about what's pulling you toward accepting a refusal too easily. Dispatch wants you back in service, your shift ends in 30 minutes, the scene feels sketchy, or, and this genuinely happens, the patient just enjoys the attention. None of those are good reasons to let a refusal slide.
Patients don't refuse care randomly. The reasons repeat call after call. We're going to walk through 7 categories: feeling fine after treatment, fear of cost, distrust of the system, denial of how serious things really are, a preference for privacy or a different plan, the high-risk refusal from a fully competent patient, and the classic, "somebody else called 911, not me." Once you can name the reason in the moment, you can actually address it instead of just fighting it.
This is the most common refusal you'll run. You fix the problem, and now the patient feels normal, so why would they go anywhere? A diabetic gets dextrose, a seizure patient comes back to baseline, someone's pain goes away after a treatment, and suddenly they're fine. The catch is that fine right now doesn't mean stable. For a hypoglycemic patient, the honest version is, your sugar dropped low enough to cause this. We don't know why yet, and if it happens again while you're driving or alone at home, that's a very different outcome than it happening here with us standing next to you.
Opioid overdose deserves its own slide. You give Narcan, the patient wakes up, and now they want to leave, sometimes actively upset that you reversed their high. Most of these patients still need transport for observation in case of a secondary overdose as the Narcan wears off, and often for things beyond the overdose itself, infection sites from IV use, or a mental health resource they wouldn't otherwise access. If your protocol allows it, consider holding Narcan unless there's respiratory compromise, and bag valve mask the patient into the truck first. Sometimes, after a few minutes of ventilation, you may not need Narcan at all, and you've bought yourself a much better negotiating position in the back of the ambulance instead of on someone's living room floor.
Money is one of the biggest silent reasons patients say no, and they often won't say it out loud. You'll get, "I'm fine," when the real answer is, "I can't afford this." It hits uninsured and underinsured patients hardest, and for some patients who came from countries where an ambulance ride isn't a covered service, the fear is even more automatic. Address it directly and honestly. EMS transport is often covered in emergencies. Hospitals have financial assistance programs, and nobody is turned away at the door for being unable to pay up front. Say that out loud. It changes the conversation.
Some patients aren't weighing risk and benefit at all. They're reacting to history. A bad experience at a hospital, a language barrier that made them feel unheard, or a community where calling 911 has meant police showing up alongside the ambulance. You're not going to undo that history in 5 minutes on scene, but you can meet it with something concrete. I know hospitals can be overwhelming. We can advocate for you and keep you informed the whole way. That's a promise you can actually keep.
This one is quietly dangerous because the patient isn't lying to you, they're lying to themselves, and they mostly believe it. It's just heartburn, just a pulled muscle. Older patients and people with chronic conditions are especially prone to this because they've had these symptoms before and normalized them. Underneath it, there's often real fear. If I admit this might be serious, I might not come home. Your job is to gently separate what they hope is true from what your assessment is actually showing.
Sometimes it really is just preference. They'd rather see their own doctor tomorrow, they can't miss a shift at work, or they just don't want to sit in an ED waiting room. Fair enough, as long as they're competent to make that call. Two groups need extra attention here. Intoxicated patients or patients with a behavioral health crisis may look like they're making a preference, but impaired judgment can undercut real capacity. When it's unclear, call medical control. And elderly patients living alone sometimes refuse out of a quiet fear that going to the hospital means they won't come back home, that they'll lose their independence. Naming that fear out loud can open the conversation more than any clinical explanation.
These are the calls that keep providers up at night. A patient who is fully alert, fully oriented, absolutely competent to make decisions, and their ECG shows changes, or they have stroke symptoms, or they just came back from an arrest and now they're refusing. Age over 65, abnormal vitals, and a concerning history are your red flags to slow down, document heavily, and strongly consider involving medical control before you accept that refusal.
The patient genuinely didn't call you. A bystander saw a fender bender, couldn't answer dispatch's questions, and you got sent out as a precaution. The patient may have any of the reasons we just covered, or they may simply be right that this never needed a 911 response in the first place. Either way, document who actually initiated contact. It matters.
Everything we've covered funnels into one framework. Your role is not to force anyone into the back of the ambulance. It's to make sure they have what they need to decide in line with their own values. That means covering 4 things every time: the risks of refusing, the benefits of going, the alternatives available, and confirming their understanding. 2 documentation mnemonics build on this: CURED, covering capacity, understanding, risks, education, and decision, and the more detailed Case Closed, which walks through condition, assessment, statements, education, consequences, limitations, the offer of transport, signature, and documentation. Pick whichever your agency uses. The point is having a repeatable structure so you never miss a step.
Let's make this concrete with the chest pain example. On condition and limitations. Our ECG shows changes that could mean your heart isn't getting enough blood. We can't do the full labs, imaging, or monitoring here that the hospital can. What seems mild now could be a blockage that worsens suddenly. On risk. Without further evaluation, this could progress to a heart attack, an irregular rhythm, or even cardiac arrest. People in similar situations have ended up needing stents or ICU care, or worse if they wait. And on benefit. At the hospital, they can run tests to rule out serious issues quickly, give stronger medication if needed, and get you home safely with a plan. Transport doesn't commit you to anything beyond evaluation. Notice, none of that is a threat. It's information. How you say all of this matters as much as what you say. Never say, "You have to go." That's a command, and commands trigger resistance. Start with empathy and partnership. I understand you want to stay home. That makes sense after feeling better. My job is to make sure you know all the options so you can decide what's best for you. Use we and plain language instead of jargon. We're concerned because your blood pressure is high and the ECG isn't normal. Let's look at what that might mean. And swap the vague, alarming "you could die" for something specific and relatable. Similar patients have had their condition worsen overnight, leading to emergency surgery or permanent heart damage. Here's what the monitor is showing. Specific and real beats vague and scary every time.
When a patient objects, you should already have the response ready. Don't improvise it in the moment. For cost, EMS transport is often covered in emergencies, and hospitals have financial assistance. No one is turned away for inability to pay upfront. For fear of hospitals, I know hospitals can be overwhelming. We can advocate for you and keep you informed. And when someone declines transport with you specifically, but clearly still needs care, you've said you don't want to go to the hospital with me, but that doesn't mean you shouldn't go seek medical care soon. That last line matters. It separates "I won't ride in your ambulance" from "I don't need any care at all," and it puts the responsibility for that gap clearly on the record.
This is the single most important technique in this whole presentation. Don't ask, "Do you understand?" Everyone says yes to that. Ask them to teach it back to you. Can you tell me what I'm concerned about and what could happen if you stay home? If they can explain it in their own words, you have real informed refusal. If they can't, you haven't actually informed anyone yet. You've just talked. For high-risk cases, bring in family members, your supervisor, or online medical control. And remember, persuading a high-risk patient harder is completely ethical, as long as you're using empathy, not threats.
Document, document, document. That phrase shows up over and over in EMS legal literature for a reason. Your documentation may be your saving grace if a refusal ever ends up in front of a lawyer. Capture vitals and exam findings, the actual content of the conversation, who witnessed it, your capacity assessment, and specifically that you explained risks, benefits, and alternatives, and that the patient demonstrated understanding, not just that you mentioned it. Get the signature, or document a verbal refusal and why there's no signature. Note any medical control contact, and if you're wearing a body camera, that footage can be some of the strongest protection you have.
Capacity isn't just, are they awake and talking? It's 4 specific things. Can they understand the information you gave them? Can they appreciate how it applies to them personally? Can they reason through the options? And can they express a clear, consistent choice? Alert and oriented times 4 is the shorthand most of you know, plus the absence of anything impairing, intoxication, altered mental status, a psychiatric crisis. If any of those 4 pieces is missing, you don't have a valid refusal, no matter how firmly the patient is saying no.
Getting the signature is sometimes the hardest part of the whole call. Patients ask, "What am I signing?" Answer honestly. It's a standard refusal form. Here are the main points, and you can have a copy. If they still won't sign, that's not a dead end. A police officer or firefighter from another agency on scene can witness either the signature or the absence of one. And if there's truly no signature and no witness available, document the verbal refusal in detail. What was said, by whom, and when.
For any high-risk refusal, chest pain with ECG changes, stroke symptoms, post-arrest, do a full exam, document vitals thoroughly, get family involved if they're present, and call medical control. When capacity itself is in question, intoxication, altered mental status, a psychiatric crisis, the default should be to err toward transport under implied consent. Bring in law enforcement if you need help safely doing that, and get medical control on the phone before you accept any refusal. One scenario the article doesn't cover directly, but that you will absolutely run into, an injured or sick minor with no parent on scene. The general rule across EMS is that a minor cannot validly refuse emergency treatment or transport on their own. A parent or guardian has to be present and has to agree with that refusal. Here in South Carolina specifically, state law says a minor who's 16 or older can consent to health services themselves, short of an operation. And separately, minors of any age can receive necessary health services without parental consent when the treating provider judges it necessary, again, short of an operation. On top of that, the same emergency doctrine we use for adults applies. If there's a real threat to life or health, you've made a good faith effort to reach a parent and can't,
and it's unsafe to wait, you treat under implied consent. So here's your on-scene order of operations. Try to reach a parent or guardian. If you can't and the condition is emergent, treat and transport. Don't accept a refusal from an unaccompanied minor. Get medical control on the phone. Loop in law enforcement or notify social services if something about the situation looks like neglect or abandonment. And document every single contact attempt with a timestamp. One more thing. South Carolina lawmakers have proposed tightening parental consent rules, so this is a good area to double-check with your medical director periodically. This slide is training guidance, not legal advice. When in doubt, treat, transport, and call medical control.
Let's practice. Your patient's sugar is corrected. They feel completely normal and they live alone. They want you gone. Turn to the person next to you and talk through it. What's the specific risk you explain, given that there's no one else at home to notice if it happens again? What alternative do you offer? A call to their doctor tomorrow? A family member to check in? And what absolutely has to be in your documentation before you clear this call?
Next scenario. A minor fender bender. The patient has neck pain, but says they feel okay and wants to just drive home. What hidden risk are you explaining? Remember, occult injury and swelling can show up hours later, especially once the adrenaline from the crash wears off. And if a family member is going to drive them instead of calling us back, what do you specifically tell that family member to watch for and when to pull over and call 911?
Last scenario. Tying back to what we just covered. A 15-year-old at a school event has a severe allergic reaction, gets epinephrine, and starts feeling better, but there's no parent on scene, and the student wants to refuse further care. Can this patient legally refuse on their own? Who is your very first phone call? The parent, dispatch, or medical control? And practically, what does erring toward transport look like when you're standing in a school gym with a 15-year-old and no guardian in sight? One of the authors of the source article flew Boeing 747s for over 20 years before this second career in EMS, and he compares a refusal conversation to a cockpit briefing. In the cockpit, risks are briefed out loud so everyone understands and agrees before anything happens. Treat every refusal the same way. Brief it out loud. Confirm capacity. Complete your assessment and document vitals. Explain risks, benefits, and alternatives. Get the teach back. Offer a follow-up plan. Get the signature and a witness if you can. If there's no signature, document the verbal refusal. Call medical control for anything high risk, and always close the same way. Call us back anytime, no hesitation. That's your captain's brief. Run it every time, no exceptions.
4 things to carry out of this room. Refusals test your communication skills far more than your clinical skills. Anyone can start an IV. Not everyone can talk someone into getting the care they need without a fight. Treat every refusal as a chance to educate, not a loss. You can fully respect a patient's autonomy and still actively work to minimize harm. Those aren't in conflict. And document like your certification depends on it, because on a bad day, it genuinely might.
Before we close, 3 questions to talk through as a crew. First, think of a refusal call that made you uncomfortable. What would you do differently now? Second, where specifically are you going to use teach back on your very next refusal? And third, a practical one. Do you actually have your medical control contact ready for tonight's shift? Patients rely on us to help them make the right decision, even when they start the conversation by saying no. That's the whole job in one sentence. Thanks for your attention today. Stay safe out there.